effect of anesthesia on BOLD signal and ASL signal. And I'll explain why that's important. But first, I have nothing to disclose except that I'm MD, so I'm not afraid of terms like case-based anymore, but I'm more familiar with patient stuff and clinical stuff. So very quickly about moyamoya. It's a very rare cerebrovascular disease, and it's basically the stenosis or occlusion of the distal carotid artery or the proximal middle cerebral artery. And you get these typical moyamoya vessels surrounding it, basically collaterals bypassing the stenosis. And these patients, they present with TIAs, infarction, hemorrhage, and cognitive decline. And they have an age peak around 6 years old and 40 years old, so often very young patients. So you can treat them with bypass surgery. And what you basically do is you put the SCA, so the superficial temporal artery, from outside the skull to inside the skull, and you connect it to the MCA. And you check that with this intraoperative images, where they use ICG to ICG fluorescence to show that the bypass is patent. This is quite an invasive procedure, so especially for those young patients, you need to be really sure you need to operate before you actually operate. So that's why cerebrovascular reactivity measurements are essential for the treatment planning and follow-up. So the treatment planning is done in the hospital. So before you decide to actually operate, pre-operative planning is done. So standardly, it was a DSA and MRI, and it used to be always a PET-CT at our hospital. But that was a very lengthy process and very expensive, and it also used ionizing radiation for both the DSA and the PET. And for the PET, they had to go to another hospital, so it's very cumbersome, especially if they had to use narcosis during the and general anesthesia during the procedures. So recently we changed this, and we changed the PET-CT for an MRI protocol using ASL and BOLD. So our standard preoperative protocol is now just an NGO and an MRI, including CVF and CVR measurements, which now includes, well, it looks like this basically. So this is a patient of 6 years old who presented with TIAs and some numbness in her arm. And here you can see that the CVR is very low bifrontally and right parietally. So she was operated, and a year later, the CVR increased, and her complaints also disappeared. So that's how you can use the CVR images. And that's also why it's very important that the CVR images are correct, because if they show steel when there's no steel, they can operate patients that don't need operation, or vice versa, that you think it's all right, and then patients get an infarction. So that's why it's very important that this information is correct. So now this is a standard protocol. So this is how the ASL images are now imported in our clinical protocol and the clinical PACS viewer system. All right, so those patients, CVR is essential for treatment planning and follow-up. Only the patients are young and they have cognitive decline, so it's very hard to scan them. So they often use general anesthesia for these pediatric scans. So traditionally, we use PET under anesthesia at the VUMC at Amsterdam. But there's not a lot of literature about the use of CVF and CVR measurements during anesthesia. And the general assumption is that CVR is not influenced by general anesthesia. But we did notice some differences between awake and anesthesia patients in response to Diamox, because that's the vascular stimulus we use during the CVR measurements. And our hypothesis was that anesthesia actually depresses CVR, so it is reduced by the effects of the medication. So we compared all pediatric moyamoya scans, and it was 10 awake and 8 patients under anesthesia, to see if there were any differences. So we used our, and because it's different patients, so it's not the same patient scanned awake or under anesthesia, we use the cerebellum as a comparison, because the cerebellum is usually not affected by the moyamoya. So this is our protocol in a single awake patient. So we first start with the ASL baseline scan. So here you see the cerebellum and higher up supratentorial. Then we start a 15 minutes BOLD scan. And after a minute, we start the Diamox infusion, 1.5 minutes. And you can see the rise of the CVF in both the cerebellum as the whole brain. And here in the brain as well. And after the BOLD scan of 50 minutes, we repeat the ASL scan. So here's the CVF after the Diamox challenge, 12 minutes later around. And you can see the increase of the CVF and also the delta CVFs increase. So here's good CVR in both cerebellum as in the cerebrum. So you can see the increase. So if you compare this to a single anesthesia patients, they have very comparable baseline scans. So the comparable CVF levels for both the cerebellum as the cerebrum. But you can see that during the BOLD scanning, there's less increase of CVF. And also after the BOLD scan, this post DIMOX CVF, there's less increase. So to compare back, this is from 0 to 3, and this is from 0 to 1. So it's almost a factor 3 less. So that was just a single patient. This is the whole group, so 8 narcosis patients, 10 awake patients. They are not completely the same, but very similar in disease characteristics. So the patients that are awake are a little bit older, which makes sense because older patients tend to be more reliable to lie still for a while in an MRI. And there's more moyamoya syndrome in the group that's under narcosis. But apart from that, they're pretty much comparable. And because we use the cerebellum, they are very much comparable. So if you look at the group results of the BOLD scanning, we can see it's very much different. So here you can see the mean of the BOLD with a 95% confidence interval, and on the y-axis it's the person's BOLD increase, and the x-axis is just a second. So this is almost 15 minutes. And you can see that there's a very steady raise in the awake patients. This is basically what we expect, but it's way less in the narcosis patients or the anesthesia patients. And if you normalize the curves, so it's now normalized to the maximum increase, you can see that the peak is also way earlier in the anesthesia patients. And after a minute or 5 minutes, it actually goes down again. So here you see a downward slope, while expected to stay stabilized for like an hour or something at least. So it's a very distinct difference. So we see that's a different slope, different final amplitude, and a different time to peak. And all those 3 things are also highly significant difference. So that's also very big plus of our protocol, that we use dynamic BOLD imaging during the DIMOX injection, so you can actually see these differences. Because usually it's just the baseline scan and some standard anatomical scans in between, and then a post DIMOX scan. But that's also what we did. So we also have the ASL scans, and then the baseline scans of CVF are similar. So we see similar perfusion of the cerebellum before, but the difference is there's more increase in the awake scanning and less in the anesthesia patients, and also there's the delta is different. Only this is not completely significant, unfortunately. This effect is less big than we saw with the BOLD scanning, but I'll get back to that why that is a bit later. So we saw that the responses to the DIMOX are clearly different between awake and anesthesia patients. We saw that the peak is earlier and the response is lower for both the ASL and BOLD. But BOLD has a way bigger effect. So why would that be? There are several explanations, but we're not really sure, and it's also not very much looked into. But what we think is there's a difference in the baseline condition. So the anesthesia also has an effect on the vessels. Depends a bit on what kind of anesthesia you use, but it can be vasoconstrictive or vasodilatory. So propofol or something has more vasoconstrictive effect, and inhalatory anesthetics like sevoflurane have more of a vasodilative effect. So that can maybe predilate the vessels a little bit or preconstrict. So you don't have a proper baseline condition anymore. And this could lower the difference between pre and post DIMOX scans, which could lead to lower CVR. Apart from that, anesthetic can also lead to lowering of CMRO2 or lowering of CVF by itself. Anesthesia patients often use oxygen because the anesthesiologist needs to take care of the patients, and if he sees that the oxygen gets lower, he just infuses more oxygen into the lines. If he sees that the blood pressure goes too low, he also used drugs to pump up the blood pressure as well, which could also affect the CVF and CVR. And they use tubes, making it you have a bigger area of dead air ventilation, which could also affect the BOLD measurements, for example. You can also argue that it's not only the baseline, but also the response to acetazolamide in itself. And that could be explained by the fact that when you give acetazolamide, you get a bit acidic, and patients respond by hyperventilation a little bit. And we're not really sure if that's the same effect in awake or patients under anesthesia. Maybe patients under anesthesia are just hyperventilating more because they don't have a cerebral effect of dampening that response. But we're not really sure. We can't really see it from our data yet. And there might be an interaction between acetazolamide and the anesthetics. It's not really described, but we're not really sure as well. And that's also the most striking actually from this project, that there's not really a lot of data on actual patient data with awake and general anesthesia compared. So we're not really sure what we're looking at. So that's actually the most important conclusion. So there's different CVR response during anesthesia, and this directly impacts the CVR maps of anesthesia patients, which is important since these maps are very much used for clinical planning. So we need more research in the same subject studies, ideally, to see how this correlates with the spatial maps, if it's in some regions or all regions, and if you need to correct for it. And until that research is done, it's very important to use caution for interpretation of CVR results using general anesthesia, because we're not really sure what we're looking at.